move now to a panel discussion, again echoing the different pillars of the partnership that persisted for so many years. You have the full biographies in the overall program, so I will be very brief. We're going to start with Brenda Colatrella, who comes to us from Merck. Then we have David Mwakisa from Tanzania, the critical country partners, Simon Bush, who also gives us a perspective from the civil society, from the NGO community, and Rafe Henderson, who speaks very broadly, but including the multilateral, the international development organizations. We're going to hear from each one of the panel members, and then we'll have an exchange. I encourage each one of them to pose questions to the others. Again, remembering that our central question here is, what do we learn from this rather remarkable partnership? So I'll start with Brenda and ask you, look, you have a particular role on corporate social responsibility, on many aspects of this private sector engagement. But as you look backwards, but also as you look forward, what made this work? What were the ingredients in this secret sauce? And even, I think we might also say, what might we have done better? What might be some of the lessons? So Brenda.
First, I just want to thank the task force for including me in today's summit, and to also recognize Bruce's important contribution to telling the story. It's always a pleasure for me to talk about the Mectizan donation program, and especially to reconnect with some old friends and colleagues. I only wish it could have been in person. As Catherine mentioned, I currently lead Merck's corporate responsibility function, and I've had the privilege of being involved with the Mectizan donation program in one capacity or another almost since its origin, about 5 or so years into the program. At Merck, we view this program as an incredible success story. So in thinking about why has this been the case, I don't know if there is exactly a secret sauce, but I can certainly point to several important ingredients, as others have already this morning. So first, a medicine Mectizan that was available as a result of Dr. Vagelos' courageous and unprecedented decision in 1987 to make Mectizan available to all who need it for as long as needed for river blindness. And then, of course, the program was later expanded to include lymphatic filariasis. It was a medicine that lent itself to mass or community-directed distribution. There was critical funding to finance the operations of the effort, which was very important. There was strong, proactive support from international and multilateral agencies, a resilient and committed group of NGOs that served as an early catalyst, an enduring element of this effort, and the enthusiastic Ministry of Health and country-level commitment and ownership. These are just a few, I think, of the key factors. From my and Merck's perspective, all of these elements are absolutely essential to this program's success. But in my mind, there's a difference between a program and a partnership. And this was and continues to be a true partnership, as others have also mentioned this morning. So that's the key characteristic I want to focus on for a couple of minutes. One of my most vivid memories was actually from many years ago when I was sitting around the table of an NGO coordination group meeting. And I distinctly remember being so inspired by the spirit of collaboration and camaraderie that I witnessed. At that meeting and in many discussions related to this program over the years, there were very few, if any, egos or personal agendas, just an overwhelming desire to ensure that the people who needed Mectizan received it, and that ultimately this devastating disease would be brought to an end. I firmly believe that those enduring personal commitments have served as a key driver during the more than 30 years of this program. Much has been achieved since the early days of the control program, and the partnership has certainly evolved. But we know there's a lot more work to be done. Now, many endemic countries and their partners are actively engaged in strategies and programs focused on elimination. The inclusion of the elimination of transmission of river blindness globally as a target of the WHO NTD roadmap released last week formalizes the commitment of the countries to this shift. As we at Merck reflect on the past success and what is needed to meet this new ambitious goal, we have identified several key priorities to support the Partnership for Elimination that I wanted to share today. First, continued operational research and collaboration among endemic countries to identify and share best practices. The shift from control to elimination requires new tools and strategies to define the scope of the programs, measure progress, and ultimately determine when the program goal has been achieved. Importantly, the sticky issues, such as cross-border transmission and co-endemicity with LOA have to be addressed. Evidence based on experience is necessary to inform the development of these tools and strategies. And collaboration among countries is vital. It's vital to share these experiences, align on global strategies, and support cooperation where it's needed. The leadership and guidance at WHO. With the inclusion of the elimination of transmission target in the NTD roadmap, WHO has led the way for the global community to rally around the elimination agenda. We thank WHO for this leadership. With this ambitious elimination agenda, WHO's guidance is needed to bring countries and their partners together in support of a collective approach. The continued commitment of long-standing partners to see the program through to elimination, as well as revitalize support from donors and partners who are integral to APOC's success. It's actually amazing to see the individuals and organizations that supported the early days of the program still here and committed to seeing the partnership through to achieve its ultimate goal. That dedication continues to inspire, and the wealth of knowledge in this community is very deep. We're also hopeful that the collective focus on elimination will revitalize support from some partners and donors. And needless to say, we're now also faced with an even more complex and challenging global health environment. So this focus, commitment, and collaboration to accomplish our elimination goals are needed more than ever. I'd like to end where I started, with a hats off to the many individuals that were so instrumental to this effort thus far. Actually, too many to mention, but I would like to just recognize one person, and that's Charlie Fedig, who many of you may remember. Charlie spent the bulk of his career at Merck and played a critical role in the earlier years of the Mectizan donation program. Sadly, Charlie passed away just a couple of weeks ago. For me, Charlie is a terrific example of the power of individuals to contribute and make a difference. I know that of all of his personal and professional accomplishments, his contributions to this program were a true career highlight for him. I think many of us share that sense of pride of having had a part in this effort. And I know all Merck employees are proud to be part of a company that demonstrated such bold and compassionate leadership back in 1987 that is now leading to the elimination of a devastating disease. As Dr. Vagelos stated in his recorded remarks, Merck's original commitment to the river blindness community was to provide Mectizan as much as needed for as long as needed. We're proud to continue to fulfill that promise and be a partner in onchocerciasis elimination. And our thanks and gratitude go out to all of the many partners who have never stopped believing in the possibility of eliminating river blindness globally. Thank you.
Thank you so much. Let's now turn to David Mwakiusa, who has a large role here in representing essentially the many countries that were involved over so many years. So what do you see as the major elements that made this so unusually, shall we say, and remarkably successful?
Greetings, everyone from Tanzania. I come from a country which has 31 regions, 7 of which are onchocerciasis endemic. And that has put 6 million people at risk of infection. But we have some success stories. In the time I have, I can't give you the preference rates and how they have improved. Suffices to say that currently we are conducting a stop MDA research in one of our foci. The research is aiming at determining whether we can stop MDA or not in that focus. The research idea came following the latest prevalence rates, which were reported to be 0 or near 0. So we seem to be in the right direction. I thought in my short presentation, I should make an appeal to my fellow Africans who reside in onchocerciasis endemic areas kind of to revisit our role in the whole scenario of partnership. We realize and acknowledge that onchocerciasis is a problem in our society. It negatively impacts on the welfare of our populations. It affects the health of our people. It reduces their productivity, and in turn, it disparages the economy, both personal and that of the country. Having realized that, each country should resolve to put measures in place to alleviate the problem. The responsibility to fight the disease is on the shoulders of each country. Nobody is going to do that for us. We have to take up that responsibility. Each government should do the planning, organizing, evaluating, and executing all the intervention programs. That means that each government should own the intervention programs. In this regard, we expect maximum political will and political commitment. In my country, some 3 decades ago, onchocerciasis and other NTDs were not given much prominence in the whole field of healthcare, including budgeting. As early as 1997, core implementation of CDTI had been operative in some locations, but it was not until the year 2009 that an NTD secretariat was established at the Ministry of Health. The program coordinator is a medical doctor who is specialized in public health and epidemiology. And the program has also established secretariats at regional and district levels. So we have these regional and district coordinators in the whole country. As I said earlier, the governments in endemic areas have to shoulder this responsibility. They should own and direct intervention programs of NTDs. After all, they are the ones who know local customs, and beliefs. Witchcraft is rampant. And again, every program should have a component of training and retraining. This will help us in building our own human resources capacity. But most importantly is that NTDs should in our programs. To have an NTD budget has its own advantages because it will absorb any unpredictable shocks in the event of sudden withdrawal of donor funds. As you know, there's donor fatigue. Sometimes priorities change, or economic downturns, and also political upheavals. And it means if you don't have an NTD budget and any of these things happen, you are going to paralyze your activities. So the emphasis here is that each government should have a budget for NTDs, and any funds which are injected into the program by donors should be considered as a bonus. The funds which are set aside for these intervention activities, that we should be on top of business because there are many holes, administratives. Some can be used for travel or hefty allowances, and those are things as a program director we should be able to plug any holes that can divert these funds to what they were not supposed to do.
The accountability mechanisms, making those work. We should move on then to Simon Bush, who's highlighting the non-governmental, the civil society. What do you see as the major lessons, the major elements of success here?
Thank you, Catherine. And Don Hopkins outlined many of the areas in which NGOs were involved with in OCP and APOC. There's an awful lot of learning to summarize, and it's really difficult to do that from the early work in the 1950s, the inspirational work of Sir John and Lady Jean Wilson that Bruce's book outlines so well, to that work around piloting the community-directed approaches, often to a very skeptical global health establishment. And I think Bruce really brings out that in his book, and now to the implementation on the ground with a large number of partners. The role of these organizations is as varied as the members of this wide group, but we are all working to a common mission. And firstly, let's remember that the control objectives of the program have been largely met. Let's remember that the disease causes blindness, and a reduction of the levels in blindness caused by onchocerciasis is evident. And now we move to elimination. So what sort of role do non-governmental organizations have in that? And it's as David was talking about, supporting the country leadership, supporting national onco task forces who set the country elimination agenda. Technical expertise, providing global advocacy, that bigger picture, mobilizing resources, and really challenging to identify the gaps. Building the capacity of the health system to sustain elimination has to be a key. Operational research, and being able to ensure that work continues in areas of conflict. Elimination sets the goal really high. We can't have a menu of countries that we can pick on to work in. We have to work in all endemic countries to ensure that the elimination goal is reached. From the very start of the programs, there was always that challenge to ensure that the wonderful donation of Mectizan reached all the at-need communities. And I think the NGDOs have been a part of that process. And this is where we talk about the partnership. Not one organization or not one type of organization can claim the success. It is the real source that you were talking about. And I think the key is integration and coordination. I think we get very hung up about what definitions of those words are. I think to get the answer, just ask a busy frontline health center, and they will tell us exactly what integration and coordination is. They do it all the time. I think the use of more sensitive and less invasive diagnostics is key. Let's say no to skin snips that really are not acceptable to the communities. Thinking about how we support the health system to achieve post-treatment surveillance. Thinking now about building the data set which proves elimination, the elimination dossiers. Completing required surveys now where we know where countries have likely met elimination targets. And it's been picked on a few times by Bruce in the book and in the introduction. The biggest challenge now is to maintain momentum to the end game. The end game is elimination. As I've said, control is largely met, but we have not achieved elimination in Africa as yet. We have that 10-year process to go through. Non-governmental development organizations have come together from those early meetings in the 90s. And the NGDO coordination group is still here. It's still that core group of the old members, but standing very firm with new members too. And I think the lessons are coordination and the development of best practice and implementation, excellence in program management, the ability to get to scale and sustain that scale, and also the long-term support. You can't have 1 year support to an onco program. If you're in it, you have to be in it for the long haul. My own organization, like many others, have been involved since the early days, and we're still here and we're still committed. Maintaining partnerships. It takes time and it takes a lot of effort, and it sometimes requires compromise and disagreement. But it's the time that we need to invest to make sure that those partnerships are alive. Flexibility is something that we all need to have, especially when we're working in very complex political environments or countries suffering from insecurity. Having a common voice on advocacy using a consistent data set will really help us reach the end game. Making sure that that operational research is applied to meeting challenges. That quick application of the research is required. We don't now have the luxury of time. And this program is all about access and equity. It's about leaving no one behind. And I think as we look forward, we need to keep in mind that early work on development of the community participation and the involvement of communities. We shouldn't forget that work. The concept is as strong today as it was when it was developed and trialed in Nigeria, Uganda, and Mali. Thank you, Catherine.
Thank you so much. And so let's now turn to Rafe Henderson. I guess helping us to navigate the sort of multilateral dimensions, the international world.
Thanks, Catherine. My role principally is to talk about WHO. And as both Jean-Louis has said and Tori has emphasized, and in Bruce's book as well, our history in this program has not always been the most glorious or flexible or estimable, I would say. And I hope that current WHO leadership, and particularly with Moeli now with the roadmap and other initiatives that are being taken, we can have a brighter future than we've had in the past. One of the things that Bruce emphasized and was, in my view, very true, was the independence of OCP from WHO. It wasn't totally independent. There were some links. We were not only the sponsoring agency, but the executing agency. So we were intimately involved, and will be intimately involved in all these future health initiatives. But the independence was important for many reasons, but one of the most important from my perspective was the independent evaluation, the fact that there was evidence provided to the various partners that was seen to be accurate and outlining what the real problems were. You can't really manage without knowing what you're managing at, and needing that evaluation to bring credibility to the donors and make them confident in carrying on their roles. It was mentioned, I think, by Jean-Louis, at least, the neutrality that was provided by the structure of OCP, that no particular institution was seen to be the owner of it, and therefore not defensive, particularly about its either successes or its failures. But I think that in OCP, undoubtedly, the bank was the major driving partner, albeit behind the scenes. But without Bruce's absolutely stubborn and dogged pursuit of the program, I think it would not have been successful in sustaining its financial contributions. And of course, those are the main things that allowed all the other elements of the program to be effective. I'll end my presentation there, since the discussion maybe highlight other points. Thanks.
Well, thank you all so much. I think we have a rich menu and unfortunately very little time. I did want to ask just one question to Jean-Louis, that this program has really taken place over an extraordinary period of history of Africa, with wars and turmoil and refugees and changes in narrative. Do you have any quick comment on the sort of geopolitical issues, the sort of geopolitics of how you see this story meshing with the story of Africa?
That's quite a question, Catherine. Thank you for it. Well, my sense is that I'm almost tempted to say that there is an acceleration of the kind of conflict that can get in the way of continuing progress on NTDs. That my sense is that, you know, the example that throughout the book Bruce talks about in the case of Sierra Leone shows that this was a rather contained, tragic as it was, and there was an ability to get back and catch up. If I think, for example, today of how would it be possible to do more in the areas that fortunately are no longer endemic in the areas of Niger, Mali, northern Cote d'Ivoire, which has raked with real the kind of violence that we haven't seen in a very long time. So to some extent, we are lucky that the program achieved at least control and in some cases more in regions which today, my sense, unfortunately, is that we wouldn't be able to get there in a very effective sort of way. If you see the evolution of the situation in Mali, for example, where the many instances in the book where Bruce talks about the ability of getting pastoralists and agriculturalists to really talk to each other. Unfortunately, now with the growth of terrorism and worse, these people are killing each other. So I see a real way in which in a sense, the timing of the conflict at the time was limited enough to permit getting people at the end of the road, which would be inaccessible right now. So it's a bit pessimistic, but I must say that the situation in the Sahel in particular is quite problematic.
Yeah. Well, thank you. That's a sort of hint, I think, of topics that will be discussed later in the day. I think, unfortunately, we're coming to the end of the time allocated for this session, even though we're just at the very beginning, I think, of the discussion. I wanted to end, I have 7 points that I've sort of drawn out that I think we can remember. And what I think is compelling in having this right now is that we are saying time and time again that if everyone is not well, if everyone is not reached, none of us are safe. And in a sense, we had a foretaste of that challenge in the case of the ONCO program, where it was the remarkable capacity of Simulum danosum, the fly, to travel for such distances that in a way forced a regional program and therefore highlights a number of lessons. I also come back to what we lived in the World Bank, but which again, I think is a very topical issue, the degree to which these issues of health are so fundamental to development, way beyond the human element. They are vital because they affect the capacity to draw on opportunities. They're linked to education, to jobs, to every other aspect. And it was that message to McNamara way back in the early 1970s that really took the World Bank and other organizations onto a much broader and more ambitious agenda on health. And the other issue is how relevant these lessons of partnership are still today. I'm very much involved with the Ouagadougou Partnership right now, which covers many of the countries that were involved in the ONCO programs over the years. And it has a very different partnership model. I'm convinced that there's much that could be learned. And you have then the group of 5, you have the alliances around the Ebola crisis. You have so many different challenges, which I think does come back to one of the real issues over the years, which was the fact that there were so many competing priorities, so many other diseases, so many other crises, and therefore the determination to stick with the ONCO program was vital. So my 7 points, number one, I think, was that the cause was so compelling. All the way from the plague upon the land, linking the agricultural potential to the human health issues was vital, but it was also a narrative that had to adapt and change over time. The problems of the scientific complexity also affecting the way that the program had to be presented. And then with ivermectin coming in, a change that was necessary in the narrative. But through it all, the basic cause of alleviating suffering that people could relate to was really critical. The second point is the enormous challenges that Bruce's book goes into in great detail of dealing with not one bureaucracy, but multiple bureaucracies. And I know the World Bank bureaucracies, constant questioning, constant efforts to look for something new, which we all know. And I think that what was needed was what we so rarely celebrate, which is bureaucratic courage and the attention to monitoring, the attention to accountability. Third, clearly money was very important, and the way in which the financial management worked, which is something Bruce goes into in great detail, the way that it was possible to maintain this very complex multi-sectoral partnership with financial support, but also financial controls through conflicts, through disputes, et cetera, was very important. The fourth was the lessons that we've learned about what it takes to have a regional approach. In Africa specifically, but I think more generally. And many new instruments were developed here that do have applicability in other places. Fifth, the technical excellence and the research links, the communication was critical. The flexibility, which a number of you have mentioned. And then finally, I come back to where I started, which was the extraordinary personal commitment. It was heartening to hear people say that the egos were left aside. I'm not sure they always were. People are people. Institutions are institutions. But there was, I think, a remarkable story, which is a human story of how people make a difference, how each one of the people who's spoken here played critical roles and made a big difference. So with that, we'll move on to the next segment. Back to you, Patricia. And thank you to all of you so much for your insights and for your commitment.
Thank you, Catherine. And of course, thank you to the speakers and the excellent contributions and for providing great perspectives colored with some personal anecdotes around the ONCO effort, rich histories with insights into partnerships, some quite nuanced, made for a wonderful balance of vital information and of riveting storytelling. Now, it's clear from all that has been said so far, together with the dog barking in the background, to reinvigorate programs and strive towards elimination in ONCO endemic countries will require not only regional stability, and that the ingenuity and resilience that we have witnessed occur on the African continent. I think, Catherine, you mentioned during Ebola, for example, can be tapped into. But it's also novel ideas and strategies into the future. I recall that the new roadmap 2021-2030 launched last week. We heard Dr. Moeti, the WHO Regional Director for Afro, mention new global knowledge sharing tools that could certainly be of use in data management and mainstreaming of ONCO programs. So it's a very exciting arena. So let's delve a little deeper into this with our next panel under the title Innovative Methods and Tools, that will be chaired by Yankum Dadzi former director of OCP, again with extensive invaluable experience, scientific and technical, hands-on project management and understanding in both ONCO and LF. On the panel, and for the sake of timekeeping, I will keep it very brief. Azodoga Seketeli, former director of APOC, who will speak to vector control and vector elimination. Michelle Pack, former river blindness program coordinator at Sight Savers. We also have Tor Godal joining us again, former director of TDR, who'll speak to operational research. Also on that topic, Frank Richards, who's a senior advisor for river blindness, lymphatic filariasis, and schistosomiasis programs at the Carter Center. Jean-Louis Sarbib, former Senior Vice President, Human Development and Vice President of the Africa region at the World Bank, and Bernard Lees, Chair, Department of International Health, Georgetown University, and former Director of Health Services at the World Bank, who will join Yankum Dadzi. And for introduction and framing of the conversation, Yankum, I hand over to you with a quick reminder to our audience that questions can be submitted, so please feel free to do so. Submit them through the Q&A option on Zoom. Yankum?
First of all, let me start by adding my voice to appreciation to Task Force for Global Health, TFGH, for having set up this symposium. And also, I would like to thank or show up a great appreciation to Bruce. I think it's been a very important initiative. I know he's worked very hard for it, and I think what has come out is excellent. And Bruce, it's a beautiful thing that you've recorded what has been a good history for all of us and for the people who have benefited from that. And I think they will all appreciate it. Now, to go straight to the point, this has been a change. We've listened to the sources that have made a partnership. Now we need to look at the technicalities that went into being to get what we have. I don't want to remind us about what onchocerciasis is, but at least we need to look at what existed in terms of the disease, because that is what actually has made the change and brought about all the things we're going to be discussing. Now, the disease really was debilitating. I wouldn't say is, it was, because now we've come to a point where the disease are no longer seen. The disease was associated with stunting growth, with epilepsy, in addition to the well-known disfiguring skin lesions, including subcutaneous nodules and depigmentation of shins, together with the unrelenting itching, and the eye lesions that led to reduction in visual acuity, so visual reduction in vision as well as blindness. The blindness, particularly, was the prominent thing in the Savannah area where onchocerciasis control went, and it is important to recognize how the blindness caused the incapacitation of communities. A lot of communities had people, adults aged 30 years plus, 50% of them being blind or severely visually impaired. And that was the incapacitation that brought a lot of misery in the areas, and survival was even questionable. Now, at the time, onchocerciasis control program was started on the Sabine country program, which later extended to add another 4 countries. There was no effective and safe drug. So vector control was what was available. Vector control was effective, was proven to interrupt transmission, but it was high technical because of the large area, the spraying of the riverside to interrupt the transmission had to be done aerially. It was certainly expensive, but it turned out to be cost effective. But then there was also the possibility that there might be some problems with vector control. So at the beginning of the program, operational research was a key component, and we'll be coming to that. Now, fast forward, it was a big change in 1987 when it was reported that mectizan was effective and safe for the treatment of river blindness or onchocerciasis in humans. And what was even more, and it had been registered, and what was even more interesting or compelling was the fact that Merck donated the drug for the treatment of onchocerciasis for as long as it was possible. That, of course, was a big tool and welcome at that time for the OCP, which was able to have a second tool to work with. And that managed to bring the program to an end in 2002. Now, the availability of mectizan also allowed then control programs to start in the rest of the 20 endemic countries in Africa that was outside the OCP area. Which came under the EPOC program. And with that as well, there was the possibility across the Atlantic, in the Americas, in the South and Central America, to control 6 countries which were also onchocerciasis endemic, under the onchocerciasis elimination program for the Americas. And 4 of those countries are now certified as having eliminated onchocerciasis. Now, the question that was available, that was to be posed, was how the useful drug was to be delivered in the populations that needed it, in the communities. So we needed to develop delivery approaches, sustainable approaches in the community. At the same time, we also needed to know how effective the drug was going to be in controlling onchocerciasis. And here also operational research was component. With this introduction, I would like to invite Dr. Seketele to present the first item in the panel, vector control and vector elimination. Dr. Seketele is an entomologist with great passion who entered the program at the beginning in 1976, left the program, transferred to Trypanosomiasis Research Institute, but then came back in the middle of the 80s to assume the position of chief of entomological evaluation. Later, of course, he became coordinator for the program and was a manager for the APOC when it started and became its director 4 years later. Dr. Seketele, you have the microphone.
Thanks very much, Yankum. Good afternoon to all. I hope you are all hearing me from Lome. Thanks very much. Yankum, you said it all. I have nothing to say more, but let me justify my presence here by adding few words. Thanks very much. In the absence, as Yankum said, of any drug eligible to mass treatment of the affected populations, vector control was the unique means adopted to combat river blindness in Africa, especially in the core area, as illustrated in this fantastic book of Bruce Merton, book that we are all celebrating today with great pleasure and proud. Thanks very much, Bruce. Every week, evergreen or Viking helicopters fly over the rivers, spraying insecticide to kill larvae of the similion fly. And this operation, as Yankun said it earlier, aimed at interrupting the transmission of the disease by the biting adult fly. Only one insecticide called Temephos or Abed was then used. The success of these operations was straightforward. With the annual biting rates as well as the annual transmission potential of the flies brought to very low level. Unfortunately, soon after the launching of the operation, the treated zone were reinvaded by fly coming from outside. And also, Temephos, which was used, the similar flies find it useful to them to go resistant, to develop resistance to this Temephos. So, treated area reinvaded, flies resistant to Temephos. I was saying that the program was in danger. And here, all the stakeholders, all the partners came together, put together their effort and thoughts to overcome these two challenges, reinvasion and resistance of the fly to Temephos. As a result, one, the OCP area has been extended to include 4 more countries, bringing the total to 11. 2, 6 more insecticides were discovered and used in a rotational basis every week. You can see then how powerful was this partnership. From February 1975 to 1988, vector control was the only way of controlling onchocerciasis in the 11 OCP countries. From 1988 to the end of OCP in 2002, vector control operation was supplemented by a treatment with ivermectin or metizan donated to the program for as long as needed. The availability of remectisone has made it possible to bring first OCP to what I would call a peaceful end in 2002. Most importantly, the availability of that drug donated, I repeat, free by Merck for as long as needed, protected and is still protecting the tremendous achievement of vector control operations in the 11 OCP countries. No doubt that without this mechanism, APOC could not have been launched to cover the remaining 20 endemic onco countries in Africa. I invite us, if it's not yet done, to go back to Bruce Benton's book to see really how powerful was this partnership and the lesson we all learned from it. We are all still learning from it for the benefit of the poorest population in Africa. Warm congratulations to Bruce Benton again, and I would like to thank you all for your kind attention. Thank you.
Thank you very much, Dr. Secretary, for the insight into the vector control aspect of the programs we all love and worked in. At this time, I would like to introduce Dr. Michelle Paquet, who will be delivering the next program on the next item on the panel, ivermectin and community-directed treatment with ivermectin. Dr. Paquet is a senior health expert in JSI, and he came there with 35 years of experience from all sorts of health issues, starting through maternity, child health, public health, from Africa and Asia. The most important aspect of his work, as far as we're concerned, and that is with onchocerciasis, is started when he directed phase 4 community trials of ivermectin in Liberia. And then later on, he assumed coordination of site savers programs in 5 countries in West Africa. The important thing about Michel is he has very interesting ideas of delivering ivermectin in the communities, which departed from what OCP had conceived to do or was doing because of what it was used to. I will recognize that it was Michel Paquet's idea, which was developed further to have what we now use as a CDTI. So with this introduction, Michel, you have the microphone.
Thank you, Yankum, and thank you, Bruce, for writing this wonderful book. I'm only adding a few details to what Bruce so well wrote down in his book. My story actually starts in 1987. October 1987 was when Merck announced his plan to donate mektizan for as long as needed. The story of ivermectin was ivermectin's discovery, the development, which even led to a Nobel Prize for William Campbell, and now the donation by the pharmaceutical industry revolutionized the approach to controlling neglected tropical diseases, is however not my story to tell. For me, 1987 was the year I finished my master's in public health at Hopkins. Sir John Wilson actually played a significant role in elevating the profile from river blindness, and he gave our commencement speech when I graduated. At the same time, I had met Dr. Richard Semba, who had done some studies on onchocerciasis with Dr. Hugh Taylor at the International Center for Preventive Ophthalmology, Wilmer Institute in Hopkins. They are conducting some trials on onchocerciasis, and Richard told me that Dr. Hugh Taylor was looking for someone who was willing to go to Liberia. They were going to do the phase 4 clinical trials on ivermectin after the successful previous trials. All I knew then, after a little bit research, was that ivermectin really looked very promising. It had less side effects than DEC, which was actually, as I knew from my personal experience working as a district medical officer in what was then called Zaire, now the DRC, quite complicated to administer and had very severe side effects. So the next thing I know, Hopkins hires me and I'm in a partners meeting. So there was the first partners meeting that was between Hopkins, TDR, there were people from Merck there, and we discussed jointly the outline of the protocol for this study. Hugh Taylor assigned me to write the operational director manual, and as director for field operation, I went off to Grand Bassa County, where we had another partnership with the private sector. The Lac Rubber Plantation actually took care of some, let's say, financing, lodging, staff contributions, and so on. The 3-year trial had as main objective to test the safety of the drug. We were going to treat a population on the plantation of some 14,000 people during the next 3 years. So yearly treatments 3 times. Periodically checkup of everyone treated, first 3 days and then monthly to detect and document eventual side effects. Not only investigating the side effects, we also had some side studies following the microfilarial load, the parasite density in the skin, and incidence of new cases. So our first challenge was we couldn't treat because the drug hadn't been tested in children or pregnant women. As we all know, those are vulnerable groups and need special guidelines and research. So first challenge was how to identify children under 5. There were no ID cards, there were no birth certificates. So I thought about this old Belgian approach to identifying children under 5. You just ask them to put their hand over their head, and if they can touch their ear, they're probably over 5. So that took care of identifying children under 5. Next challenge was the guidelines were 150 microgram per kilogram. So are we going to weight everyone, calculate doses? That seemed a little bit cumbersome. So we took bathroom scales and color-coded the disc. And depending on the code, it was half a tablet, 1 tablet, 1.5 tablet, and so on. Later, this innovation became the dosing poles. Someone already mentioned those. Identifying pregnant women was actually a more difficult question. Women wouldn't know or wouldn't not share that they were pregnant in the first 3 months. Luckily, from TDI gave us a follow-on grant, and a year later, we examined actually every child under 1 by a group of pediatricians. They were blinded to the modest treatment or non-treatment to see if there were any negative outcomes on children or on development of the child. then what to do with dead people? How would we attribute deaths, which were one of the serious adverse effects we were looking at, to ivermectin or not? So we developed verbal autopsies. 3 years later, when we looked at the results, we were actually, as many people were, amazed. We had 95% plus compliance. So the drug was really accepted. The microfilarial load, by the way, 80% plus of the population treated had been infected. The loads dropped by 80% 2 years on, so just before the third treatment. So it was not just after the treatment, it was after 2 years treatment. 80% dropped in filarial load. We also had a little study following black flies and their transmission potential, and there was a 45% decrease. So all in all, if we compared that to what OCP had accomplished in the previous years by vector control, it looked really very favorable. No severe birth effects, no severe effects on adults, and no deaths attributed to ivermectin. We had a small problem though. Ivermectin tablets at that time came a 6 milligram tablet. So I wrote a letter to Merck explaining to them that most of the people we treated actually needed half a tablet. And if you knew how small the tablets were, when you break a tablet, you ended up with crumbs. So I suggested they produce 3 milligram tablets. Philippe Gaxot at the time told me, Michel, this is not so simple. And indeed, it took about 7 to 10 years before we had the 3 milligram tablets. Now, if you think about those 3 million tablets, a box of the 500 tablets, the whole box is as active ingredients as much as 3 aspirins have. And then imagine that with 1 kilo actually of ivermectin, you can treat a whole health district. I was kind of saying, wait, we need to get this out. So I said bye-bye to my academic career and decided that I would build on my previous experience as a district medical officer and go work with communities and try to get this drug out. Luckily for me, Sightsavers was looking for someone, and they had just joined the partnership to control. We didn't call it eliminate, and it was control river binders, and sent me off to Bamako. I left my pregnant wife, was pregnant with twins then in Baltimore. No worries, we're still happily married. And off I was to Bamako. So the challenge was not how to treat individuals. We saw it as a challenge how to treat communities. You could not just pick and choose a few people or even pick a few villages. We really set out to treat districts. How would we do that? Lining up everyone at the health facility, inviting to come on Monday, and then going on Tuesday, Wednesday, Thursday till everyone was treated. That was out of the question. Others tried that and wasn't very successful. Mobile teams, that was a possibility, but quite expensive. So we needed to expand the partnership. We needed the communities to work with us. And then we thought about how do we get everyone, the compliance was very high. How do we get this compliance? So it was very important to get the trusts. And trust starts with informing people. We never, even looking at side effects, never told people there were no side effects. We actually warned them there was going to be itching. And itching was actually considered like a proof it worked. And also it made us really looking well because, hey, those guys, we could predict the future. They told us it would happen and it happened. Those people really know what they were talking about. Then there were other side effects, positive side effects. We didn't have to tell people that ivermectin would also kill a few worms. They came and showed us handfuls of worms. So the drug was actually really popular. other things he needed to do was stick to appointments. People don't want to come and line up for something and then you don't show up. So we learned that early on. And then I thought back how we organized communities and the importance of task shifting or task sharing. We don't need a doctor or we don't need the nurse to do every medical procedure. In Zaire, we had nurses doing C-sections, and in the blindness community, we had nurses doing cataract surgery. So how far can we task shift? How far can we task share? So what can the doctor leave over to the nurse? What can the nurse leave over to the community extension worker? What can the community extension worker trust the community health worker or the village committee can do? Okay, so we were ready to go. And then we had a few villages where no one could read or write. And as we all know, in programs, you need reports. Who was going to write a report in those circumstances? From our side, we developed pictorial recording forms, which also kind of served as memory aids. Other villages found a solution for us. They say, oh, don't worry, just don't tell us to do it this month, but in 2 months, so-and-so, he yearly comes on vacation here, and he can read and write. So would you agree that we do it in 2 months? Yeah, of course we did. And then we had a low coverage because some people, when we worked or at the plantation in Liberia or in village, were absent. So we agreed with communities, yeah, those absentees are not the real problem. Like if you just leave the drug here, villages arranged themselves. We didn't tell them where to keep the drugs. They would say, oh, the community volunteer, they're young guys, they can walk around. But when it comes down to keeping something as valuable as the drug, we will keep it at the chief's house. Also, the circumstances, the house is bigger. So communities started to take on more and more responsibilities. So at the same time, we had also invited people from other countries to Mali to see what we were doing. And so this was then community involvement repeated in Nigeria, Uganda, and other countries in which Sightsavers was active. I traveled to quite some countries. But still, I was thinking about when we were in Zaire, we had only one fridge, and we invited villagers to come to the hospital in the morning, pick up the vaccine, and then they had an appointment with the nurse from the closest health center, would come to their village and vaccinate. The only condition, I told the village, we can do this, but I need to get that cold box back before the ice pack melt so that the vaccine doesn't expire. So we said, why don't we do the same with ivermectin? So it turned out that I was not the only one who was thinking about community participation and collaboration. And one day, I remember we were sitting in a room in Bamako with Hans Remy. Bake, you were there. And brainstormed and came up with community self-treatment. You know already from Bruce's book that seemed to be unacceptable to some people, and it was rebranded to community-directed treatment. That's when we had TDR come in again. They sponsored some multi-country research, and some of the investigators, which I see you, became later director of APOC. So community-directed treatment was actually the final big partnership, community partnership. So they played a bigger role, and they still play this big role. So I think giving control to communities is difficult. but in my opinion, it was key and still is key to defeating onchocerciasis. So this way, it's no longer my story. It's now the story of each different community. I left Sightsavers after 10 years in 1997. Told my kids, 10 years killing worms, that's enough for me. But in my current job, I still visit many villages, and many times I've seen dosing poles. Janko, it's the end of my story. Thank you.
Yes, Dr. Goodall, please. Dr. Goodall is an international public health specialist who is currently working as advisor to his country in public health affairs. We know Dr. Goodall for his innovative creativity in all public health affairs, and we work very closely together in the OCP days when you were director of TDL. So kindly have the microphone.
Thank you very much, Malcolm, and thank you, Michelle, for your wonderful story. And it's easy for me to follow on, then taking how I remember it and from the TDR perspective. So after it was clear that Roy Vagelos had made a decision to make it free of charge, available as long as it was needed, a critical question was how one could distribute ivermectin. Because if it required nurses and doctors, you wouldn't get very far. And the critical question in relation to that was safety, as Michelle have touched on. And so we then organized, and part of it was in Liberia. I think it was around 100,000 people that then went into phase 4 trials with the aim of studying the safety, because the clinical trials had only been about 3,000 people. So one could have rare but very serious side effects. And then the conclusion from those really randomized end-of-the-road trials showed that ivermectin was extremely safe. And as Michelle has indicated, we also found out that actually that it was not harmful to pregnant women or to offspring from pregnant women. So that meant that one could have basically a distribution system which was not dependent on educated health personnel. The next question was then how it should be distributed. And there, in my memory, social scientists were very keen on community participation, and the medical mafia was very keen that it should be linked to the health services. And so we decided, and it may well be in the meeting that Michelle was referring to with Hans Remme and so on, since Hans Remme was a critical part of the design of these studies, was to do multi-country, multi-center studies where we randomized villages. And in half of the villages, the health center decided who should distribute ivermectin. And in the other half, it was the community. And the community, the leaders in the community that decided. And then we measured the level of coverage and the compliance. And believe it or not, the compliance and the level was better when the community decided who should distribute ivermectin. And of course, you can understand that it would be a trusted person and so on. And so in my memory, that was decisive, because now you had quantitative information to demonstrate that when communities decided who should distribute ivermectin, you got better results. And that was then the start of and coined the term community-directed treatment. Then we had a PhD student in TDR called Usha Amasigo, and she went to a clinic with onco patients, and she observed that they were all itching very much, and that was something that was really not known at that time. But of course, itching is very, it's very troublesome for the people, and moreover, as has been shown in studies, that if you look at the disease burden, how people feels disease burden as compared to what medical assessment says, there is a very big correlation, except for one kind of diseases, skin diseases, because skin diseases like leprosy and onchocerciasis leads to social exclusion. So in my view, that was really a very fundamental study, and that then led to larger studies again on the impact of ivermectin on skin disease and itching. So that was very important to settle. And then the last point was relating to, then of course, we didn't know where in Africa do we have onco skin disease. So it was a question of epidemiological mapping, and it was a question of developing rapid, simple epidemiological mapping so that you could really quickly be able to draw the map in Africa, as also then we have seen earlier here today. So I think these were some of the key operational research issues that we addressed, and this was during the period from the late 80s until then APOC was launched. I think it was 1995 or 97, but it was then we really knew how to apply ivermectin, and as I think Plato said, all important decisions are made on an insufficient basis. And you could say that Roy Vagelos' decision was made on an insufficient basis because we didn't know then how to actually get the drug to the people that needed it. Thank you very much.
Very much, Dr. Godel, for keeping to time. Thank you. Now, I would like to request Dr. Frank Richards, to present his part of operations research. As you know, Dr. Richards is the director of Carter Center River Blinders Foundation, a river blinders program, together with lymphatic filariasis and schistosomiasis. And he's also the chair of the steering committee of the WIPA. And I'm sure he would like to give us some insight into operations research in WIPA.
Thanks
Frank,
very much, Jakob. Greetings to all. I really think it's fun to be able to come together virtually around the occasion of Bruce Benton's new book, River Blindness in Africa. Congratulations, Bruce. I wish we could all be together, and maybe we will be someday once COVID is over. If you look at your agenda, the assignment is to talk about innovations in operations research, or OR the how. So to start with basics, the English interrogative words who, what, when, where, why, and how. I'm addressing just one part of this, but please remember the orientation of my remarks. That is, the who will be the Carter Center from the OR perspective, and what we were able to do with our partners that included communities, ministries of health, the Lions Clubs, and of course, APOC, over the time period 1997 to 2015. That's the when, if you will. And I will endeavor to make 4 points through the lens of some contemporaneous publications on OR for Onco. Thus, my first OR point that I'd like to give across, especially to the young folks in the audience, is you absolutely must publish your work so that there is a permanent timestamp record documenting at least part of the scope of the world's knowledge at a given time. That is then available for future river blindness historians who will follow Bruce, because we all know this story is far from over. The other 3 how questions I'm going to address in the following slides are how to fund operations research, how to get ideas for operations research, and how to focus on OR to affect policy change. And this last how will be oriented to the special APOC challenge of moving from a vertical program to an integrated program in the time period nearing the end of the program's funding in 2015. Now you can put the slides up for me. So how to fund operations research. And my answer to this is through different funding streams. And the example in this case is operations research done by NGOs, or largely with funds from NGOs within APOC projects, and focusing on what I call the deep blue, or the deep blue ocean opportunity, to look at all sorts of things related to CDTI, which we've talked so much about. Michelle just gave us an idea about. So if we look in the upper left, here are some questions addressed by Moses Katabarawa, a social scientist who's worked with the Carter Center for years, and before that with the River Blindness Foundation in Uganda. Like the question, why do some communities succeed and others fail? Or involvement and performance of women in CDTI. Or in rural communities, how can you use the kinship clan system? How can you go actually in another layer within communities to bloodlines and relationships of kin? In this period of time is actually a 10-year period of investigating this, discovering that kinship systems can enhance CDTI, increase the involvement of women, and decrease the demands for incentives, which has been a big issue. The other thing looked at, this case in Nigeria, with Uche Amazigo, led by Chinyere Maduka, looking at women as service recipients rather than deliverers, mistreatment opportunities for pregnant or nursing women. How can this be improved in following up to get them treated? Another important bit that was looked at was the very important issue of sustainability, which from the very beginning was an important outcome of APOC. And here we're looking at the selection and validation of indicators for monitoring CDTI sustainability. And then these last 2 papers were related to the important issue of integration, how CDDs, community-directed distributors, could be integrated into health services and enhance delivery of an integrated healthcare system. Next slide. Here, we're talking about how to get ideas on operations research. And the answer to that one is have a meeting. And in this case, I'm reporting the 2002 meeting on eradicability of onchocerciasis. Dr. Hopkins mentioned this with the Gates Foundation. President Carter actually came to hear the final plenary presentation of recommendations. And, you know, if I'd had time, I would have gone around in that photo on your right and talked about 14 of the 64 participants. Obviously, time and it doesn't allow me, or the size of the image. But suffice it to say that the point to be made is that industry, NGOs, and academic participation was there, as well as programmatic participation by OEPA, APOC, the OCP, TDR, World Bank, and the Technical Consultative Committee. There were 4 former, present, and future APOC directors there. And Dr. Dadzi was the meeting rapporteur and the lead author on a 140-page publication. Now, the person in red in the middle is Dr. Maria Niera, who was the WHO Geneva director of the program responsible for NTDs in that time. And she was very keen to have international guidelines for both the Americas and for Africa to allow for stopping MDA and certification, if you will, of elimination. There were guidelines produced by Geneva in 2001 and later under Dirk Ingels in 2016 that resulted in a lot of Stop MDA and 4 countries in the Americas verified free of elimination. Now, this particular meeting was focused on the elimination of transmission, not the elimination of onco as a public health problem, APOC's original goal. And the important outcomes were considering all the experience in Africa and the Americas for a rounded perspective. We got Gates funding, or the partners got Gates funding for the famous TDR Mali Senegal elimination of transmission study. And by the way, having a meeting is the modus operandi used effectively by core NTD at the task force. Next slide, please. Last point, how to put things logically and operationally linked together for operations research to result in policy change. And here, a very interesting publication that Dr. Hopkins mentioned on linking LF schisto with oncocontrol in an APOC project resulted in a very interesting interaction at the Technical Consultative Committee that I was on at the time. And I think my colleagues on this call will remember it being pointed out that under the guidelines and the rules, legal regulations of APOC, it was a vertical program. And you could not use APOC funds to do LF or schistosomiasis until things were changed. Also, what was important was the discovery that LF and onco really did go well together, and they ought to go together. It's the same medicine, after all, in Africa. But integrating schisto with the CDTI program was much more difficult. Last to mention is, next please. You there? There we go. Onchocerciasis and lymphatic filariasis elimination in Africa, published in Lancet Correspondence in 2015, with Darren Evans from the World Bank, Tom Unash, and myself, all of us involved in the final years of APOC. Next, please. And
your time is up.
Actually, I have 1 minute, 38 seconds. That'll be very quickly. APOC was highly successful, but an overly vertical control program with onco. And once APOC closes on December 31st, the programs will need to continue to fight against onco, to focus on elimination rather than control, and integration rather than vertical planning. Let us work quickly to improve science, policy, and implementation of integrated programs to eliminate onco in Africa. So slides off, please. So just to conclude in my last minute, the 4 how to do OR points that I made. Promptly publish your OR in peer-reviewed journals. Books are great, but they're not contemporaneous. As Bruce himself points out, memories fade. 2, the community of researchers need multiple funding streams so that all ideas are explored. 3, get at least some of your ideas by holding meetings with wide representation. And finally, APOC was a vertical program that, in the end, was forced by partners to shift to integration. OR should have been focused to provide evidence to these partners on how to operationally fit NTD components into integrated approaches that were elegantly simple, had measurable outcomes for all components, and saved resources. Thanks so much, stay healthy, and congratulations to the OCP APOC partners.
Now, the next presenter is going to be Dr. Jean-Louis Sabine. We've already had it introduced currently is a director for Africa and the Middle East at Centennial Group International. He was, at the time of the bank, very much instrumental with the development of Nkosekasi as vice president for Africa, and later on as senior vice president in human development. And he's going to share the presentation slot with Dr. Bernardize, who is currently the chair of the Department of International Health and director of the Masters of Science program. Dr. Lise, public health specialist, is also worked there for a long time in World Bank, and his interest was health and development. So this time, our time is really shortened. So I would like to propose that you share the time, each of you probably try and present in 6 minutes. So we'll start with Dr. Sabine.
Thank you, Dr. Dadzi. I'm going to be rather quick, and what I would like to do in this short presentation is to see how the link between health and development was lived through at the World Bank, which is mostly concerned with economic and social development. OCP really was the first incursion of the World Bank in the health sector. And what's interesting is that in reading the book and in my own experience, it started with the two things: the visit of McNamara in Burkina Faso, and basically it was a compassion story. He was really taken by the suffering of the people that he saw, the abandoned villages, the abandoned good health, but there was an implied economic and development rationale, but mostly it was a story. The second thing was that very practical man that he was, there was a theory that something could be done. And he met these French scientists in Bobo Dioulasso, and he knew that something could be done. So this was really the launch of what we're talking about today. And it took a while, and I remember very well the day that Bruce decided that he was going to write an economic analysis, a cost-benefit analysis, which he summarizes better than I can in the book. And he was very worried about what was going to happen. And in fact, this link between health and development was marked by 3 or 4 major things. The first one is an increase in labor availability, so that the people who couldn't work before could work. The second was an improvement in productivity. And this is where the story of itching and what it does to people comes very much. And these two things led to Bruce being able to calculate an ERR of, without the exploitation of the new lands, of about 6%. But there was also some other benefits, increase in school attendance. Because the young boys and girls were no longer having to lead people who were blind. And also less evident and more difficult to quantify, a reduction in social stigma. And the story of Agnes in the book is quite a demonstration of the hidden costs of the disease. So there was a link, but the World Bank took a while to get involved in health in a big way. At the beginning, the efforts were timid because the sense was that health and education were things you did after you had the resources to do it, not as real investments. So the bank started by adding health components into various projects. And it's only in 1981 in Brazil that the bank did the first self-standing development health project. And it had a lot of components, but I will spare you because we don't have much time. Now, it's hard to link these difficult beginnings of the bank investing in health with what is happening today. And the links between health and socioeconomic development now are not only well accepted and understood, but they are becoming an increasingly a driving force in many development activities. To give you a number, at the end of 2019, the World Bank had invested 59 billion in health. It had invested 1 million in 1970. So that you could see the enormous link. But more importantly, there is now a very rich research agenda and research findings on the links between health and good economic and social outcomes, particularly in obviously the NTDs, obviously increasingly the non-communicable diseases, but also in early child development with vaccines and nutrition. And now, recently, the World Bank has included the development of human capital as one of its key performance indicators. And in human capital, the share of health is very high. So you really have an increasing and powerful link between investments in health and results in economic and social developments. Just as a reminder, I was thinking of a meeting that when I was in charge of Africa, we had with all the ministers of finance. And Jim Wolfensohn was then the president of the World Bank, was chairing the meeting. And it was at the beginning of the debt reduction initiative. So all the ministers of finance were very excited to talk to the president of the World Bank about reduction in debt. And Mr. Wolfensohn said, I will not talk to you about anything until you talk to me about what you're doing about HIV and AIDS. So that there was a very clear sense that nothing good in terms of economic and social development could happen until that horrible pandemic was brought under control. And that led to the World Bank involvement in HIV. And then we saw this with Ebola. And I need not remind us, since we're all on Zoom, of the connections between COVID-19 and economic and social development. And the World Bank there as well is really very heavily involved in trying to do this. So what started as a compassion story with potential economic benefits has become a full-throated support of the investment in health as a significant contribution to economic and social development. For the benefit of time, I will stop here. Thank you very much.
Thank you, Dr. Sabine. We now pass it on to Dr. Lise.
Yeah, thank you, Janko. Greetings to all, and a thank you to Bruce for writing the book and for writing it, as I would say, from the vantage point of a closely engaged actor. I would like to focus on impact on development and some what I would call unkempt thoughts about that. Jean-Louis has eloquently describes the trajectory of the bank. Let me just add, the bank formulated a first health sector strategy in 1973. It allowed quite limited finance for components, etc. The river blindness program was mentioned with half a page. The second health policy paper, 1980, allowed the bank to lend for freestanding health projects. It was solidly anchored in primary health care and the approach of the 1978 Almata Conference. And the paper had several pictures from the program. But I hate to say, it had only one sentence on the program itself. Was the river blindness program unimportant? Not at all, not at all. The contrary, it had its own identity, it had regional country political support, it has assured financing, and most importantly, it has independence. Rafe has drawn attention to that one. It was independent from WHO, and it was not a typical mainstream bank operation. This independence really served it. And, as we would say today, it was consequential. Consequential in a way beyond the health sector sometimes. The ONCO program shaped these control approaches, as it is clearly beyond any doubt, which has been articulated today so many times, established the centrality of partnerships and the centrality of operational research. Operational research as a foundational element of any disease control program. Let me use the example of insecticide resistance and its unintended consequences. When DDT resistance and subsequently chloroquine resistance emerged in the malaria eradication program, the program was stopped. Practical alternatives were not available. When abate resistance hit, which was anticipated, there were several, actually, as Azedogo said it, 6 insecticides ready. The impact on target organism and flora and fauna was known. Could they immediately be used? No. First, the spray beams of the helicopters had to be adjusted because the pesticide had different viscosity. So rotating ones were installed. Now it was easy to change between insecticide. Suddenly, a pesticide rotation scheme was operationally possible. And the unintended consequence, OCP pioneered the pesticide rotation today common in agriculture. Let me stay with impact on environment. OCP created the ecological group involving key international environmentalists to ensure that there was no lasting insecticide impact on flora or fauna. That meant that hydrobiological data had to be regularly collected and evaluated. The ecological group was created, and it was given de facto a veto capacity over the use of insecticides. Science had priority, not political expediency, a key concept which has shaped the entire program. Environmental dimensions taken seriously. One more example, the 1994 ministerial meeting in Paris. The OCP undertook a study carried out by David Baldry and Professor Calamari, comparing aerial photography over 2 decades in the Upper Leraba area of Burkina Faso. It showed an increase in farming area from 5% in 1972 to 70% 2 decades later in 1993, with many new villages. Success? Yes. The enormous increase in population was first and foremost caused by the exceptionally high birth rates and regional population movements. But there were problems as well. Farmland had replaced savanna, gallery forest had been chopped down for building materials, topsoil started eroding, water quality deteriorated. At the meeting, which was well attended by ministers of agriculture and 2 heads of state, these challenges of sex, as it was called, these challenges of success were discussed and a declaration on regional principles of sustainable settlement adopted to capitalize on the window of opportunity which the program had helped to create. I mentioned the centrality of key programs, philosophy and operational research, and OCP's unexpected impact on 2 sectors, agriculture and environment. Now back shortly to health. Today, the need for community involvement is accepted as a cornerstone of health interventions. Community-directed treatment with Mectisan has contributed to this realization. It is sometimes seen as an easy way to deliver a drug. That view is missing the point. community-directed treatment has to be seen in a context. It is one critical aspect of a highly complex institutional delivery mechanism involving health services, non-governmental development organizations, national onchopsychiatrist committees, drug distribution science, etc. What the ONCO program has demonstrated is that such complex challenges are manageable when they include first the community and second, focus on partnerships. A lesson central today, I would say, to the management of health in urban informal settlements and slums. In closing, I was thinking, who has made a major contribution to the program and is rarely mentioned? The helicopter pilots. They are my unsung heroes of OCP, flying with 120 miles over a river, diving down to spray insecticide lines over the river, flying lazy aids with 3 times the gravity on the stomach, close to the river canopies, ensuring that the computer receives the satellite signal from the water buoy and calculated insecticide release appropriately, taking off on Tuesdays, returning on Friday, staying in villages, finding the refueling points. I got to know a few of them, highly competent and totally committed. They were critical. They were a part of OCP. Thank you.
Thank you very much, Dr. Lise. I think now our time is up. Are we able to make a summary? Yes.
Yeah, you've got like a minute.
Good. Well, well, the summary says what to take home is actually going to be on the operations research. And I think Dr. Frank Richards made a very important observation there. And I think that needs to be sent to the countries at the moment, when what we're dealing with is regional approach into the near future, or what is current is national programs. So the programs are working by themselves. Quite a few things are missing from the regional approach as compared with the national approach. And one of the important things is the exchange of ideas. Countries are no longer able to meet to exchange ideas, which was happening in those days in the regional programs regularly. And that is also in a way linked with operations research. So this is, I think, one thing we need to be looking at. And probably it's a silent message to WHO to look at how it will be possible maintaining very good national programs and also having exchanges, and in fact, operation research as well to be done in their countries. That comes with the exchanges, certainly. So I thank the presenters, and our apologies for running over time, and I give it back to you, Patricia.
Much appreciated. Yes, it is unfortunate that we must cut the discussion short there. Robust, informative, and certainly galvanizing the creative thinking needed to help reinvigorate the ONCO effort. Really loved what Bernard was saying there about the helicopter pilots. I think we understood that that would probably have been his second career choice if he had had the opportunity. Thank you to Jan Koum and all the speakers who managed to catch up on time. The role of women, documentation in publications, equity, just a few of the crucial points raised there. Thanks once again. And again, picking up from what Bernard mentioned there, and a lot of the other speakers have mentioned, strong collaborative strategies will be key, and we'll get to discuss different ways that these can be structured when we return after I was going to say a 10-minute break, actually an 8-minute break. I'm going to be quite strict on time. So stay with us, do return at 15 minutes past the hour. Thank you so much. We'll see you then.